Hi, it's Dr. Terry. In today's Ihca, or IHCA if you prefer, we are going to be covering a bunch of leftover topics that have not come up completely in other parts of the course. We're going to be talking about the evaluation of mental status, coordination and gait, electromyography, or EMGs, and nerve conduction studies, or NCS. Our session objectives shouldn't surprise anyone as they touch on each of these named topics. We're going to be talking about evaluating mental status, motor function, and coordination and gait. Next, we're going to talk about the history, examination, and lab findings that distinguish different forms of ataxia. After that, we'll define electromyograms and nerve conduction studies, the indications for their use, and possible contraindications and dangers. From there, we'll describe the general types of results generated by EMG and NCS, particularly nerve conduction velocity and the strength of their signal. We'll compare and contrast EMG and NCS results in motor nerve conduction studies versus sensory nerve conduction studies. Finally, we'll describe specific EMG and NCS findings and the physiological deficit seen in patients with entrapment syndromes, demyelinating neuropathies, myasthenia gravis, and Lambert-Eaton syndrome, localized versus general peripheral neuropathy, and the radiculopathies. Our first objective is to discuss an evaluation of mental status. What does it mean to evaluate mental status? Well, mental status is key to a general neurologic exam. And though the words overlap, a general evaluation of mental status is more akin to what you might include, say, in the general section of your physical exam in your TPP course than a psychiatric mental status exam, or an MSE, and certainly different than the proprietary mini mental status exam, or MMSE, that we've also covered in the clinical courses. Evaluation of mental status includes commentary on a patient's appearance, behavior, any unusual or bizarre beliefs, perceptual disturbances such as hallucinations, and cognition. The goal is to differentiate a normal mental status from an altered mental status, as well as any deficits in the examined areas. You should be familiar through this conversation with general approaches to mental status, as well as the specific instruments that we use to measure it. This next slide takes a look at different components of mental status, such as orientation, short-term memory, long-term memory, mathematics, word finding, attention and concentration, naming objects, following commands, writing, spatial orientation, abstract reasoning, and judgment. I'm not going to go through each of these individual examples, but I would encourage you to look at the slide or pause the recording so that you can be familiar with how you would test each of these different areas. For example, if you were asked to examine a patient's abstract reasoning, you should have an idea of how you might do that. You should also have an idea, for example, of how to ask questions related to gauging a patient's short-term memory versus their long-term memory. On this slide, I've included two of the instruments that are commonly used for assessing mental status. On the left side, we have the Montreal Cognitive Assessment, or the MoCA, and on the right side, we have the Mini Mental State Examination, or the MMSE. It should be noted that both of these instruments at this point are proprietary and copyrighted. However, components of these examinations are not. For example, if we look at the MoCA, the Montreal Cognitive Assessment, you can see that the white words with black background identify different areas that this test explores, looking at visuospatial and executive skills, naming, memory, attention, language, abstraction, delayed recall, and orientation. It's perfectly fine for an evaluator to ask questions looking at each of these areas to get an idea of mental status, even without using the proprietary instrument. Likewise, components of the mini mental state exam overlap and assess things such as orientation, visuospatial skills, and executive function. What I'd like you to know about these instruments is, in general, knowing what each of the instruments measures. For example, knowing that the Montreal Cognitive Assessment looks at multiple domains and has a few more elements of listening, of repetition, of language, of abstraction that might not appear on the mini mental state exam. You should also be familiar with the general scoring system in that both of these exams are out of 30 and lower scores correlate with a more impaired mental status. You should also know that each of these examinations are used primarily for screening in terms of memory, in terms of cognition. They do assess other areas, but these are screening instruments which don't diagnose anything, but they can help to highlight areas in which a patient may have deficits. On this slide, I've identified the CLOX test, the CLOX. The CLOX test involves asking a person to draw the face of a clock and do some things involving putting a time on that clock and scoring different components of how the person does the test. Please note that there's a CLOX 1 test as well as a CLOX 2 test that involve different components all related to executive function. If we're thinking about executive function, one way to describe it is being able to carry out a series of tasks in order to coordinate some type of meaningful outcome. It might involve a person performing multiple steps. For example, drawing the face of a clock, putting the numbers in a certain order on the face of that clock, and then identifying a time on the face of that clock. All of those tasks combined are a way to measure executive function or carrying out a series of complex tasks. Executive function is something that we do throughout our days without even thinking about it. The times that we, for example, might put a lunch together and pack it in some type of container to bring to work or school, to put a letter in an envelope and mail it. All of these tasks that involve multiple steps test executive function. The CLOX 1 and CLOX 2 exams are ways of assessing executive function, as is identified in the title on this page for the CLOX evaluations. On the next few slides, I'm including a review from what might have been a previous Ihca, as it closely overlaps with our discussion today. Altered mental status, or AMS, is a confusional state, sometimes referred to as encephalopathy, referring to a brain inflammation or altered status, or delirium, a state in which level of consciousness is depressed, but to a lesser extent than in a coma. In confusional states, responses to stimulation might be semi-purposeful, whereas in coma, a patient is unable to respond even to painful stimulation beyond very crude reflexes. Delirium is different than dementia because delirium is an acute status that's due to some type of medical imbalance. Patients with dementia are more at risk of developing delirium. However, dementia and delirium are quite different. Evaluation of a patient with altered consciousness is always aimed at looking at the underlying cause and trying to remove that. There's a definition here of a confusional state and mild cognitive impairment. Those are things to keep in mind from a review perspective, but will not be covered in great detail in this session. One of the things to note about delirium is that it can be life-threatening. If a person has an altered mental state, they're unable to look out for their own interests, and they may not be aware of very basic risks to their health and safety. Prompt intervention is always required in order to remove the offending cause and restore a person to as close as possible to a normal mental status. The slide highlights some examples of organic causes that can lead to these acute changes in mental status. One of the most common in elderly patients is urinary tract infections, and the slide lists hypoxia, hypercapnia, hypoglycemia, medication side effects, metabolic derangements, cerebrovascular accidents, seizures, and changes in intracranial pressure. Most acute medical issues can lead to changes in mental status. This slide and the next one take a look at how to respond to a comatose patient, as well as how to measure the Glasgow Coma Scale. These will not be reviewed in extensive detail in this session, as the understanding is that these have been explored elsewhere. However, if you're not familiar with these topics, please do take some time to review, as these will be helpful to you moving forward. With Objective 2, we're now moving into the evaluation of motor function and more into the specific tasks related to today's session. You should be familiar with the definitions that are on the left side of this slide, ranging from atrophy to hypertrophy to fasciculations and myotonia. Many students are familiar with atrophy versus hypertrophy. They may be less familiar with pseudohypertrophy, when muscle tissue is replaced or remodeled with connective tissue or non-functional material, so that the mass may appear the same, but it's full of non-functional tissue, such as amyloid or a tumor. Students sometimes also struggle with a good definition of fasciculations, which are brief, irregular twitches of the muscle. It's somewhat common in normal populations to have occasional fasciculations, but these may also indicate a lower motor neuron degeneration or injury. This is critical in disorders such as ALS, where you may see fasciculations named in a question, or you may observe these brief irregular twitches of the muscle on physical exam. Myotonia is slowed relaxation of a muscle after contraction or directly percussing it. An example of that might be the inability to quickly open a closed fist. This may be indicative of myotonic dystrophy or other neuromuscular disorders. Upper motor neuron lesions are sometimes, but not always, shown by increased resistance followed by relaxation. This is called a clasp knife phenomenon, and that's similar to anyone who has, say, opened a pocket knife, where initially it's kind of hard to open the knife, but then later in its range of motion it becomes easier. That clasp knife phenomenon is often overlapped with spasticity, and those are indicative of upper motor neuron lesions. That's different than lead pipe rigidity, which in contrast describes a uniform rigidity through the entire range of motion. This is often with what we might call cogwheeling, where a person's range of motion demonstrates certain distinct stopping points, opening again, stopping, then opening again, as if in the wheels of a cog. This most often indicates a basal ganglia disorder, such as Parkinsonism. If you look at that graph describing types of muscle tone, you can see the increased tone demonstrated by a higher elevation, say on the y-axis of each of these, and then with each successive movement or range of the motion becoming easier over time proceeding to the right. You can see normal tone being identified by a straight line, that clasp knife spasticity, the lead pipe rigidity, where it's consistent throughout the range of motion, cogwheel rigidity, again looking for that as one of the components of, say, Parkinsonism, and then hypotonia, where the entire range of motion has decreased tone. This slide is linked to a 6-minute video on how to do the motor examination from the Merck manual. It's worth considering if you are not comfortable performing a motor examination or could use some additional practice observing physical exam skills. This slide talks about muscle strength. It's a reminder of how to grade muscle strength, and remembering that this is different than the way that we score reflexes. For example, with muscle strength, a 5 out of 5 is considered a full muscle strength, where a muscle can move the joint across a full range of motion against gravity and against full resistance applied by the examiner. So plus 5 out of 5 muscle strength would be considered normal. Muscle strength can be evaluated through the use of special tools, such as a hand grip ergometer, or even by using an inflated blood pressure cuff. You want to observe a person's overall behavior with their muscle function. Are they using accessory muscles? How is their posture? Is pain impacting their strength or their range of motion? How do they do with rising from a squatting position? One thing to note is the Gower's sign or Gower's sign. Again, variable pronunciation depending on who's the instructor. What this is essentially when a person is using the hands to climb up their own thighs in order to become vertical. A person may rise from being supine by first rolling over, becoming prone, kneeling, and then again really using that force in the hands to push up. And this is suggestive of pelvic girdle weakness. There's a video link here to show you on an animation with interesting music of what Gower's sign looks like in practice. We distinguish between fine motor skills and gross motor skills, where fine motor skills involve small movements of the hands and fingers. This can include things by history, like the manipulation of buttons, zippers, using a pen or pencil, using scissors. Some of the ways that we would assess fine motor skills can be a Minnesota manual dexterity test, the O'Connor finger dexterity test, putting round pegs into holes on a punched out sheet, and it requires the extensive use of the fingertips. Some might even consider coloring, although not medically validated, to be an excellent way of using fine motor skills. You might choose to take a look at what some of these Minnesota manual dexterity tests or the O'Connor test, what those look like, and that'll give you a better idea of how those help to measure fine motor skills. Now, gait and coordination are one of those things that we'll often see when performing a physical exam, and often I see somebody say it's a normal gait or it's an abnormal gait. For the purposes of our instruction, you're going to need to know some additional vocabulary to identify what's going on with gait and what sort of different things may be going on with the patient that's impacting that gait. For example, patients with impaired proprioception, if they can't feel their feet as well, they might over-observe their feet. They might always be staring down to avoid falling. They might prefer being barefoot, so maybe they can feel a little bit more, or conversely, no pun intended, they may prefer wearing very thick shoes so that they don't damage or injure their feet. Waddling might be caused by pelvic muscle weakness. There's what's called a steppage gait, where a person lifts their leg very high to avoid catching the foot, and that can be associated with foot drop. It's easy to think of how you can apply some of the basic neuroanatomy and neurologic deficits, and then also understand how that would lead to a specific gait. You should know about how a wide gait can help a person maintain stability, and that can be caused by cerebellar problems or cerebellar ataxia. For example, if you were to see a patient with any of the disorders that affect the cerebellum, or in terms of structure or even function of the cerebellum, a wide gait might be expected. Perhaps a patient who has had significant alcohol use in their history might also have a wide gait due to cerebellar problems. You might see scissoring and circumduction associated with spastic legs. You can check ataxic movements, specifically in the area of cerebellar ataxia, by using those cerebellar tests that you've learned in your physical exam classes. Some examples include finger-to-nose testing or heel-to-shin maneuvers. You'll notice that we do have a number of different details in the image on the right side of this slide related to a damaged cerebellum and different factors that can result again in that wide gait due to cerebellar problems. On this slide and the next, we're going to look at a number of the different ataxias, and what I encourage you to think about as you're studying these different ataxias is what makes each one different from the rest. I'm going to run through these different types of ataxias and again try to highlight some of the differences. The differences that I highlight in this recording may not be the differences that stand out to you in your own studies, and that's okay. You should know about Friedreich's ataxia, and that is the most common hereditary ataxia. This one stands out because symptoms usually develop by age 25. This isn't going to be something that begins in later adulthood. And similar to other ataxias, there's problems with balance and coordination, leg weakness, even to the point of using a wheelchair, dysphagia, scoliosis, vision and hearing loss, diabetes, hypertrophic cardiomyopathy, and peripheral neuropathy. Patients with this form of ataxia do have a shortened lifespan. What I might look for here is a family history, again, because this is the most common hereditary ataxia, an early onset, and an unfortunately shortened life. Ataxia telangiectasia is interesting because you notice here not only do we have the ataxia, but we have the telangiectasia identified in the name. So if you were to see telangiectasias in the eyes and cheeks associated with the movement disorder, ataxia telangiectasia is something that you might be thinking of. Now this one is hereditary, but it's considerably more rare than Friedreich's ataxia. This often has children presenting with significant difficulty with ambulation, often needing a wheelchair by age 10. Those characteristic telangiectasias that we spoke about, a weakened immune system, and these children are at an increased risk of leukemias and lymphomas. There's also a shortened lifespan associated with this. Spinocerebellar ataxia is different than the earlier onset ataxias that we've spoken about already. This ataxia usually begins in adulthood, and it can have variable symptoms related to balance and coordination, as well as muscle stiffness or cramps, memory loss, urinary urgency, and or incontinence. Episodic ataxias, as the name implies, include rare transient ataxias, with episodes lasting minutes to hours. These are usually a result of something going on, some outside behavioral component, such as stress or substance use. This usually develops in the teenage years, and it may improve over time. Episodes may include problems with balance and coordination, muscle spasms, vertigo, migraines, and tinnitus. However, life expectancy is usually normal. So this is an ataxia that develops later in life with normal life expectancy, and it's episodic. So that's quite a bit different than the ataxias that we've spoken about already. There's also several other types of ataxia that are worth being aware of. There's acquired ataxias that can affect all ages, that develop quickly, they have variable courses. There's idiopathic late onset cerebellar ataxia beginning around age 50. There's ataxia with vitamin E deficiency that can sometimes be treated with vitamin E supplements. And there's also a gluten-related ataxia that I didn't include here, and that one's interesting because it can overlap with celiac disease, may or may not overlap with celiac disease, but is related to gluten sensitivity. This slide links a video that's about 3.5 minutes, and it's actually a video that's directed toward patients that describes and shows what an EMG and NCS look like. I consider taking a look at it. I think the video shows more than what still pictures would show, and certainly more than just what me talking about these studies looks like. We're going to get into the weeds here just a little bit and talk about electromyograms as well as nerve conduction studies, or EMG and NCS. I'm not expecting you as a result of this talk to become experts in either of these studies, but I would like you to be familiar in general with what they're indicated for, what sort of risks might be involved to performing the studies, what might be contraindications, what can affect the results, and what general results might look like. So what you need to think about in each of these exams, or the combined exam, as the nerve conduction study is often part of the EMG exam, is they use electrodes that put some type of stimulus into a muscle and or a nerve, and then we measure how effectively that stimulus is transmitted. Some of you who had physiology labs in undergraduate may have performed EMGs. Electromyography, or EMG, is going to assess muscles and motor neurons, and it can identify issues with nerve dysfunction, muscle dysfunction, or the place where those meet with neuromuscular transmission. During a needle EMG, needle electrodes are directly inserted into a muscle belly, and they record electrical activity. The nerve conduction study, as I mentioned, is considered part of an EMG, and it might use surface electrodes, or electrodes on the skin, to measure signals between 2 points. Electrodes measure electrical activity, and they feed that data into a computer that turns the signals into graphs, sounds, or numerical values, so that we can see how effectively that signal is getting transmitted. Now, EMGs can be ordered to evaluate all sorts of things: tingling, numbness, muscle weakness, pain, or cramping. They can be used to diagnose muscle disorders, such as muscular dystrophies or polymyositis, neuromuscular disorders like myasthenia gravis, peripheral nerve disorders like peripheral neuropathies or carpal tunnel, upper motor neuron disorders, such as ALS or polio, and nerve root disorders and how effectively the nerve root disorder is impacting the person, such as in the case of herniated vertebral discs. Now, if you think about what might be relative risks or contraindications to sticking a needle into a person's muscle, it's relatively common sense. There's certainly a risk of bleeding. If there's active infection or a risk of infection that can be related to this, you do this in as sterile of a way as possible. You can cause nerve injury. If you're examining areas around the lungs or the thorax, it could cause a pneumothorax. You want to be careful if a person has a pacemaker so that the electrical activity that you're introducing doesn't damage the pacemaker or cause arrhythmias. If a person's on blood thinners, you want to, of course, be sensitive to inserting a needle into a muscle or below the skin. If a person has hemophilia, that can be a factor. And finally, cool temperature is one that stands out to me, because if a muscle belly is cold, it's actually not going to transmit the signal as well as if the tissue is warmed. This slide is somewhat redundant, but it does speak again just about all of the different conditions related to nerve pathology, muscle pathology, or neuromuscular pathology that can be assessed through EMG or nerve conduction studies. You can see that we can assess focal, generalized, axonal, or demyelating neuropathies through using these different techniques. As a result of listening to this recording or going through these slides, I'd like you to have some ideas of general vocabulary related to EMG and NCS, as well as how we might graph out some of the different outcomes that result with different clinical things. This shouldn't be something that you memorize. And what I mean by that is you shouldn't necessarily look at the fasciculation EMG or nerve conduction study and memorize that graph. But you might think of how you would identify the definition of a fasciculation or spasticity and what that might look like. You might also see, for example, how amplitude, the distance, if you will, from the maximum value to the minimum value on the nerve conduction study or EMG is related to the number of axons in a nerve or to the strength of that muscle that's affected by it. You might also identify latency if a stimulus is applied at the beginning of the recording, but you don't notice the effect until much later. You might also notice conduction velocity, which could be affected by axonal loss or demyelination. You might notice that demyelination is going to have marked slowing of the overall conduction velocity, as we would expect in demyelinating disorders. And you might also take a look at how if large fast-conducting fibers are lost, you might have moderate slowing. This slide again takes a look at how a number of different presentations might look as we're looking at an electromyogram. Figure A on the left side shows us a typical normal motor unit potential, where when a stimulus is applied, you have a contraction of the muscle. We might see fibrillation potentials in denervation, where amplitude is greatly decreased in letter B. Positive sharp waves are shown in denervation in letter C. We have reinnervation, where we actually have fragmented polyphasic low amplitude potentials in letter D. And then in letter E, you might see abnormally prolonged and high amplitude motor unit potential in chronic anterior horn disease. Again, with these, I'm not expecting you to have a very thorough understanding of exactly how each image corresponds with a clinical presentation, but I would like you to have some general understanding of a stimulus is being applied to a muscle and through the nerve. And if that stimulus is slower or smaller, that can indicate a problem with the muscle or the nerve. You should be aware that we can do both sensory nerve conduction studies, motor nerve conduction studies, or mixed nerve conduction studies. This slide goes into a little bit more detail in which sensory fibers have electrodes placed over the nerve and on top of the skin to record sensory responses, whereas a motor nerve conduction study is going to have electrodes positioned over the muscle belly, and or tendon. And then we'll also have mixed nerve conduction studies that will record both sensory and motor elements. One of the most common applications that we see clinically is for carpal tunnel syndrome, especially because it is a very common intervention to have a surgical release of the carpal tunnel in order to allow the median nerve more ability to conduct appropriately. This is another slide that you can spend time on if this topic is of interest to you and learn about it in as much detail as you like. Again, I'm not going to hold you to understanding many of the specifics about this. You should have an idea, though, again, of letter A, what a normal electromyogram looks like with the stimulus being applied, as well as seeing the potentials come through the tissues, versus some of the other presentations that look differently, again, either due to decreased amplitude or increased latency. Now, I spent the last several slides telling you things that I'm not too concerned if you know or don't know. This slide is something that I really do want you to know. This is something that is incredibly important, both clinically, as well as something that is very frequently tested upon. What we see here is an electromyogram of a 59-year-old man with ocular myasthenia. What we see here is that the summed muscle potential diminishes with each successive stimulus. If we look at the response to the fifth stimulus, it's identified as being 54% smaller than the initial response. Normally, a bit of muscle fatigue is expected, and there shouldn't be more than a 10% decrease. However, in the case of myasthenia, we see with this electrical activity on the nasalis muscle that with repetitive stimuli, the muscle potential diminishes again from one stimulus to the next. With successive stimuli, we see smaller and smaller amplitudes. Here we see what's happening clinically in the same patient. We see the patient attempting to keep looking up, and as they do that, they have successive weakness with each additional effort to keep that eye looking upwards. We see ptosis and abduction of the left eye related to the myasthenic weakness that's associated with this area. If you heard myasthenia gravis and started thinking about acetylcholine and maybe a little bit of confusion with the Lambert-Eaton syndrome, or the Eaton-Lambert syndrome as it's referred to in some areas, we need to again recall this incredibly high-yield topic. It's high yield not just because it's clinically important, but also because it's frequently confused and easily testable. What we have here is, in myasthenia gravis, in the middle image, antibodies against the acetylcholine receptor that destroy acetylcholine receptors on the postsynaptic membrane. What we have in myasthenia gravis is that acetylcholine is released in normal amounts, but has an inadequate effect because there's a reduced number of intact receptors postsynaptically. Now, Lambert-Eaton syndrome, it has antibodies against calcium channels, and those are on the nerve terminal, preventing the release of acetylcholine. You should be very familiar with how myasthenia gravis and Lambert-Eaton present clinically, as well as the pathophysiology of each of those disorders. This last slide here shows EMG findings in a right common peroneal pressure palsy. And what this shows is that the latency of the appearance of the sum potential becomes longer and longer relative to where the electrodes are placed. This is really here, I think, again, if this type of physiology is interesting to you, you're welcome to explore it. It's not something that is incredibly high yield, but it is something certainly if you plan to go into neurology or spend time on a neurologic rotation, you may spend some additional time thinking about how placement of these various electrodes and needles and how that results in different measured potentials helps you identify your clinical diagnoses. All right, folks, that's it. You made it through the pre-work. Thank you for your patience and your humor. Hope you learned something here. What to expect for class is we're going to be spending some time really getting to know some of the different mental status examination tools. We're going to be practicing those and finding ways to make them more memorable. We'll also be looking at images related to some of the different presentations, the ataxias, myasthenia gravis, different tools that are used for, say, fine motor control, and finding creative ways together to remember them, as so many of the aspects of this particular lecture can be easily kind of overlapped and confused unless you do get a chance to practice with them and really develop that personal relationship and understanding with the topic itself. I look forward to seeing you in class and hope you have a great rest of your studies. Thank you.